Good evening, everyone. So, in the next 25 to 30 minutes, I'll be talking on abdominal compartment syndrome. Uh, First, let's discuss a typical case which you often see in an ICU setting. Here we have a 39-year-old male who's transferred from an outside hospital. He is in septic shock. He has been diagnosed to have acute cholangitis. Secondary to cholangitis, he is in septic shock. He was treated with IV fluids, antibiotics, vasopressors, and 24 hours into the ICU, he develops worsening hypotension, oliguria, hypoxemia, and hypocarbia. And the staff at the bedside is being troubled with constant alarm from the ventilator. Peak inspiratory pressures are going high. Abdomen is distended. So this is a setting where you should start suspecting, especially if we have a milieu like this. This is where we should start suspecting intra-abdominal hypertension. We measure intra-abdominal pressures. Blood pressure. Intra-abdominal pressures are somewhere around 26. So patient subsequently gets surgical referral. They'll do it. All the medical management is being done initially. Doesn't respond. Undergoes decompressive laparotomy. Patient improves. There will be resolution of renal, pulmonary, and hemodynamic deficits. 7 days later, abdomen gets closed and gets discharged 2 weeks later. So this is the common scenario. So what is intra-abdominal pressure? Intra-abdominal pressure is the steady state pressure concealed within the abdominal cavity. So abdomen can be considered as a rigid box, like how you see, a rigid box with partially rigid and partially flexible walls. See, the partial flexible walls are your abdominal wall with musculature, and diaphragmatic muscle, and the non-rigid structures are your skeletal structures, the bony walls. So the degree of flexibility of the walls and the specific gravity of its contents at any moment determines the intra-abdominal pressure. So coming to the definition of intra-abdominal pressure, as I said earlier, it is the pressure concealed within the abdominal cavity. Normally it is around 5 to 7, but it depends on the body habitus of the patient. So in obese patients it can go high. It is measured at the end of expiration in a supine position when there are no muscle contractions, and especially after installation of about 25 ml of sterile normal saline, and we do zeroing at the level of mid-axillary line. So I'll discuss further about how to measure intra-abdominal pressures in my next couple of slides. So the standard measurements, there are various ways which we can measure intra-abdominal pressure. We can measure directly. So as we see in patients with undergoing laparoscopy, we can measure intermittently with indirect measures like how we do with bladder irrigation methods. There are various other devices through which you can continuously measure indirect intra-abdominal pressure. So now coming to the topic, what is abdominal compartment syndrome? So it refers to the organ dysfunction secondary to raised intra-abdominal pressure. Whenever there is raised intra-abdominal pressure accompanied by organ dysfunction, you call it as abdominal compartment syndrome. It's a spectrum. So there are normal pressures. When the pressure rises, we call it as intra-abdominal hypertension. There are various grades. There are 4 grades. After that comes the abdominal compartment syndrome. But patients with intra-abdominal pressure, it's not only the pressure which is the criteria for considering one to develop abdominal compartment syndrome. Patient can still have just a mild intra-abdominal hypertension, but if it involves organ failure, they will be classified as having abdominal compartment syndrome. So, as I said, more than 12, at least 3 standardized measurements, 4 to 6 hours apart, is considered intra-abdominal hypertension. Then coming to the concept of abdominal perfusion pressure. As we have perfusion pressures across every other organs or every other vasculature, we have abdominal perfusion pressure as well. Abdominal perfusion pressure is nothing but mean arterial pressure minus intra-abdominal pressure. It is the pressure with which your intra-abdominal organs are getting perfused. So the other definition is abdominal perfusion pressure less than 60 by at least 2 measurements conducted over a period of 1 to 6 hours. These are the various grades. Grade 1, 12 to 15, mild. Grade 2, 16 to 20. Grade 3, 21 to 25. And grade 4, more than 25. Again telling you, abdominal compartment syndrome doesn't mean that intra-abdominal pressures should always be more than 25. Patients with intra-abdominal hypertension and an organ failure will classify as abdominal compartment syndrome. The other definition is, as I said, IAP more than or equal to 20 or abdominal perfusion pressure less than 60 with single or multi-organ failure. So there are various ways with which you can classify abdominal compartment syndrome. Basically the purpose of classification is to help identify or help in the management. Managing tertiary abdominal compartment syndrome is quite complex, whereas managing primary abdominal compartment syndrome will be quite easy. So primary is when there is injury or disease in the abdominopelvic region, probably secondary to a massive retroperitoneal hematoma or post patient with liver transplantation or a bleeding pelvic fracture. Secondary is when the condition is not originating from the abdomen. It could be sepsis from any other cause with rapid fluid distribution and then developing intra-abdominal hypertension because of the abdominal wall edema, or it could be major burns, or it could be a patient with pancreatitis itself. And basically conditions which require massive fluid resuscitation are classified here. Tertiary or recurrent, when you have already treated the primary or secondary abdominal compartment syndrome but the abdominal compartment syndrome persists, then you classified it as tertiary or recurrent. So coming to the incidence, so this one study showed that patients who undergo major abdominal surgery will develop abdominal compartment syndrome in about 40% of the cases. That's quite high. So probably we tend to ignore these things because we attribute the deteriorating patient conditions to the deterioration of something else. We attribute it to patient deteriorating because of infection or something else, and we often miss abdominal compartment syndromes. In patients with liver transplant, 30%, major trauma, 35%. In patients who are generally admitted to ICU, about 12%, and so on. So what are the mechanisms by which abdominal compartment syndrome develops? It's either because of increased abdominal volume or because of decreased abdominal wall compliance, or it could be because of combination of both. So what are the conditions which lead to increased abdominal volume? Patients who have ileus, gastric distension, volvulus, or pseudo obstruction. These are some of the classical cases that you routinely see. Or even intra-abdominal or retroperitoneal masses can give rise to increase in abdominal volume. Patients who have got ascites, patients can present with tense ascites, or patients can present with hemoperitoneum. Pneumoperitoneum during laparoscopy can also lead to increased abdominal volume and intra-abdominal hypertension. So decreased abdominal wall compliance can be secondary to abdominal surgery with tense sutures, abdominal wall bleeding or rectal sheath hematomas, surgical correction of large abdominal hernias with mesh, or patient who have got amphiloCV. So all of these conditions can also lead to decreased abdominal wall compliance, and even abdominal wall edema itself can contribute to decrease in abdominal wall compliance. So these are some of the factors which are combined: obesity, sepsis with septic shock, severe pancreatitis, massive fluid resuscitation, major burns, and complicated intra-abdominal infections. So what are the physiological consequences on various organs? Coming to the cardiovascular, there will be decreased cardiac output, decreased stroke volume because of decreased preload and increased afterload. So when there is intra-abdominal hypertension, it pushes the diaphragm up, raising the intrathoracic pressures, which decreases the preload. Intra-abdominal pressure itself can decrease the preload. Afterload will get also affected when there is increased intrathoracic pressures. Increased CVP doesn't reflect volume status because of intrapleural pressure, especially in patients who have got intra-abdominal hypertension. Increased CVP doesn't mean patient is volume overloaded. So left atrial to right atrial pressure gradient may be reversed. Patients who have got intra-abdominal hypertension, whenever the pressure goes more than 12, there will be venous stasis. All of this will lead to triggering of your renin-angiotensin aldosterone system, which is more common in patients with laparoscopy. Respiratory consequences: it will have a restrictive effect because it impedes the movement of the diaphragm, decreases the compliance. Airway pressure will get increased. This is one of the most common. This is one of the signs which you see with which you can identify that patient is developing intra-abdominal pressure, because ventilator will start showing high peak pressure alarms. Tidal volumes can go down. You can wrongly attribute it to patient's lung worsening, and it will also have an effect on the efficiency of the gas exchange, leading to hypercapnia and respiratory acidosis. So what are the secondary effects on the renal system? There are several mechanisms. The most common is renal vein compression. Renal vein compression will lead to venous stasis. This will lead to decrease in perfusion pressure of your kidneys. It can also cause renal artery vasoconstriction because of secondary effects of activated sympathetic system and renin-angiotensin and aldosterone activation. So the end result is progressive reduction in both glomerular perfusion and urine output. So what are the changes that happen in gastrointestinal system itself? Gut is one of the most sensitive organs which gets affected by intra-abdominal hypertension. Increase in intra-abdominal hypertension will lead to visceral hyperperfusion, impairs the venous flow, will lead to intestinal edema. It's kind of a vicious cycle. One leads to another and the cycle keeps going on. It can also lead to worsening of sepsis because of bacterial translocation, because of the gut edema. The end result is lactic acidosis and patients ending up in multi-organ failure. So conditions like this is not new in an intensive care unit, especially if you are working in a surgical intensive care unit. You see these conditions quite often. And how do you measure intra-abdominal pressure? So you might have often seen or asked by your surgical colleagues to start measuring abdominal girths, or some surgeons will come and put a hand and tell that patient has got raised intra-abdominal pressure, but these clinical methods are not very sensitive. Up to 40% of your measurement of intra-abdominal girth by measuring tapes will be accurate only 40% of the times. These measurements are obsolete now. Intra-abdominal pressure is considered as a sixth vital sign. We'll normally do it clinically by measuring bladder pressures. Spot intra-abdominal chucks just by measuring once will not help in the diagnosis. It often delays the diagnosis with poor prognosis. IAP monitoring allows early detection and early intervention before the patient goes in for abdominal compartment syndrome. So, appropriate intra-abdominal hypertension management or abdominal compartment syndrome management is based on these four cardinal principles: serial monitoring of IAP, optimization of perfusion pressures and organ function, institution of specific medical interventions to reduce IIP. If the patient doesn't respond to these medical interventions, prompt surgical decompression for refractory IVP. So, do you monitor all the patients? Do we need to monitor all the patients who gets operated? No. There are certain patients who need to be monitored. There are risk groups. Of course, yes, we need to monitor early, but earliest in the risk group before any damage is done, and we should monitor it continuously and intervene whenever the patient is developing raised intra-abdominal pressures. So, what are the indications for monitoring? Abdominal surgery is post-operative with massive fluid shifts. If the patient has had a lot of blood loss, a lot of fluid requirement intraoperatively, these are the patients who need monitoring. Open or blunt abdominal trauma, patients who need to be ventilated post-surgery in ICU, that itself will give away. Patients with abdominal distension and signs and symptoms consistent with abdominal compartment syndrome are oliguria, hypoxia, hypotension, unexplained acidosis, mesenteric ischemia, elevated intracranial pressures. So, there is a World Society of Abdominal Compartment Syndrome. So, these are the guidelines recommended from them. Patients should be screened for intra-abdominal hypertension and abdominal compartment syndrome, risk factors upon ICU admission, and in the presence of new or progressive organ failure, we should start monitoring the intra-abdominal pressures. So these are some of the risk factors. As we discussed earlier, decreased abdominal wall compliance or increased intra-abdominal contents, increased abdominal contents again, and if there is massive fluid shift, like patients who have got massive transfusion more than 10 units, patients who have got coagulopathy, or massive fluid resuscitation itself is one of the risk factors. So if there are one of the following or at least two risk factors for hypertension, patient should be in ICU and patient should also be started on monitoring of intra-abdominal pressures. Same as I discussed earlier, and we should always monitor, we should measure serially. Just one spot reading will not help in finding or ruling out an abdominal compartment syndrome or intra-abdominal hypertension. So how do I measure it? How do we measure it in our ICU? So there are various other devices. There are commercial devices. What we do is with manometers, we can use through the gastric port, through the stomach. There is something called as Simon or Spielberg devices. These devices are specially designed. There is another bladder transduction method called as Advisor. I have some images which I will be showing you. So the advantages of the standard intra-abdominal pressure by measuring bladder pressures is simple, it's standardized, it's reproducible, and it's time efficient. So this is how the unit looks like. So you have a transducer. This can be any transducer that we use for measuring CVPs or arterial lines. It will be tied at the level of mid-axillary line. You will zero at the level of mid-axillary line. You attach the pressure monitoring line to one of the ports through a needle, 18 gauge needle, and you maintain a continuous fluid column. The principle is same as you measure in intra-arterial readings, and you clamp the distant Foley bulb when you are measuring the intra-abdominal pressure, and the readings will look something like this. So in a clinical patient, this is how it looks like. So installation of 25 ml saline. You can also use three-way Foleys, classically used by urology people for irrigation. You can use this Foley's catheter for continuous measurement as well. As discussed earlier, this is one of the bladder irrigation devices which we can use, but I don't think this is available in India. So there is a continuous transducing happening. So what are the management principles? As I discussed earlier, serial monitoring of intra-abdominal pressure, optimization of systemic perfusion and organ function in patients with elevated IAP, just like we do with other organs. You'll have to increase the mean arterial pressures to maintain perfusion in these patients. Institution of medical procedures to reduce the intra-abdominal pressure. If patient is not responding to any of these measures, then subsequent surgical decompression. What are the medical management options that we have? One, to improve the abdominal wall compliance, we can sedate the patients, we can paralyze them, we can keep them in a position where intra-abdominal pressure is less. So probably having the head end elevation decreased by few degrees will probably help. Evacuate the intraluminal content by doing decompression, suctioning of the gastric ports, enemas, and putting a rectal tube to decompress the rectum and the colon. And you can also use prokinetic agents, cisapride, metoclopramide or domperidone, or even erythromycin. You can also use in patients with IBS, you can use neostigmine. Evacuate the abdominal contents. If it's an ascites, you can do a paracentesis, or if it's some fluid, we can remove the fluid from the intra-abdominal cavity. Also, one of the most common things which we often ignore is fluid management. Restriction of fluid. Patients should be started on diuretics to decrease the abdominal wall edema, or these patients may need continuous veno-venous hemofiltration. If none of these measures work, none of the medical management works, we'll have to proceed with surgical management. So there are no exact guidelines on when to intervene. So it's a clinical decision. Abdominal decompression is the only treatment, but it's not supported by a level 1 study. Indications are related to correcting pathophysiological abnormalities and achieving optimum intra-abdominal pressures. So there are various methods through which you can achieve this. There are temporary abdominal closure methods. This is one of the most popular methods because you can reverse increased intra-abdominal pressure and you can subsequently close the abdomen. Some authors even advocate prophylactic intra-abdominal, temporary abdominal closure devices. So these things are often seen, especially in patients with pancreatitis. If they go for surgery, what they do is they don't close the abdomen, because what you can see is even during the surgery itself, you can see that abdominal will be very difficult to close. So you do a temporary closure from theatre itself before even the patient gets shifted to ICU. But it is very difficult to identify where to do this. So what are the indications? Abdominal decompression, both prophylactic and therapeutic. It facilitates re-exploration, especially in patients with abdominal sepsis and in conditions where we are unable to close the abdomen. So this is one of the temporary abdominal closure methods where they have closed with a vacuum assisted closure dressing and they have done a continuous suction. So the advantages are you can continuously keep suctioning, temperature will be maintained. Otherwise, if you expose the abdomen, patients will rapidly develop hypothermia and fluid loss will be restricted with this. When you expose your gut contents, the fluid loss will be significant. So all of this can be minimized here. Only the exudative drainage is being sucked out through a negative pressure device. So various other devices that we have, we can use Bohota bag, which we most commonly have heard. There are various other patches. We have prosthetic mesh, or we have topical negative pressure, as I have shown. There are various advantages. So the best will be with the topical negative pressure, but it comes with a significant cost. So to summarize, so probably it is a whole summary of my talk. So first we'll start with monitoring. We'll identify patients who are at risk. We'll start monitoring them serially. If abdominal hypertension persists, you will start with medical management first. Start putting in an RT tube, aspirating contents, and then probably at the last step, if there is persistent intra-abdominal hypertension or if the patient goes in for abdominal compartment syndrome, you will intervene surgically. Conclusion: intra-abdominal pressure, it's a sixth vital sign. You'll measure in high-risk groups. Intravesical technique is considered as a standard method. Intra-abdominal pressure is when IAP is more than 12. Abdominal compartment syndrome is when there is organ dysfunction accompanied by any elevated intra-abdominal pressure. It need not be more than 25. Thank you.
Thank you, sir.